Welcome back to our discussion on bone health. I'm here with Dr. Marcy Goolsby and exercise physiologist Calissa Hall. In this final section, we'll be discussing when someone should seek a bone health evaluation, how different specialists work together, and what new advancements in emerging research mean for the future of women's bone health. So, first, how would someone know that they need a bone health evaluation?
Well, I think it should be something we always discuss with our regular physicians. So, in your primary care physician, regular annual checkup, I think it's always something important to talk about. And I think they should be asking the questions of the patients in terms of menstrual status and injuries of that kind. In terms of bone stress injuries, I typically say if it's above the knee, it probably warrants a further discussion. So, sacrum, pelvis, femur, femoral neck, which is hip. Those typically require a little bit more of a discussion to look for those risk factors and potentially do some additional tests like a bone density test. I also think it's important for us to think about it in our perimenopausal years, getting early screening, particularly if you have any risk factors, if you have a history of smoking, if you have a family history of osteoporosis, if you've had fractures. So it doesn't have to be a stress fracture, but if you fall and you break your wrist, that warrants a discussion. If you fall and you break your shoulder, that's an osteoporosis related fracture most of the time. So sometimes it's a fracture or an injury that sparks that conversation, but it really should just be part of our regular thought process, particularly if there's some genetic risk factors.
And do you like when you're working with your clients as an exercise physiologist, you're training people? Are there certain, um, you know, complaints or comments that your clients make that are sort of a red flag for you that you want them to get a bone workup?
Yeah, typically, if there's bone pain, if they complain of bone pain, and especially at rest, like not even during exercise, if they get a lot of bone pain when they're at rest, that's going to be a red flag. Posture changes or low back pain can be a red flag. But really, for me, it's the exercise history. It's, if they're telling me in that initial intake that they haven't exercised their whole life, or they're only doing one type of exercise and not any of the other kind of important strategies, then I'm really going to dive in a little bit deeper. Usually, by the time somebody sees me, they've kind of already had these conversations with their doctor, so we're kind of a little bit more aware of the musculoskeletal issues. So if none of that is present and they're complaining of these things, then I'm going to certainly contact the team and make some suggestions.
And talking about screening, having listened to your comments about bone health and happening when we're young, it seems almost like we should be discussing this with pediatricians. But at what point do you think people should start to be screened for bone health?
I think it comes down to those risk factors. I mean, there are general recommendations from the organizations on when to screen for osteoporosis, but it's going to depend on somebody's risk factors. So there is a saying that osteoporosis is a pediatric disease. And the reason people say that is because it really is something that's critical throughout our whole lives. So we should be thinking about it in the younger population. So making sure that our pediatricians and our primary care physicians are asking appropriate questions for screening, particularly if they're noticing weight loss in an athlete where they might be concerned about an eating disorder, those kinds of things, and making sure they're thinking about the bone density. And if somebody does get diagnosed with an eating disorder, and there's certain diseases as well where there's a kind of a baseline bone density, something that might affect their absorption, like celiac disease, for example, or ulcerative colitis, where they may get a baseline bone density test, and that's something they might follow a little bit more closely just because of the risk of malabsorption or not absorbing the nutrients, or in the case of somebody with an eating disorder, to having that impact on the bones.
Well, currently, when is if for just a general, normal, healthy woman, what is the
Depends on what
recommendation?
organization you
Oh, is
ask.
that I was
Yeah.
I oh,
Yeah. So, um, 65 is the typical number, but I think that there's discussions
wide
about.
variation.
Right. Yeah,
Yes,
and I think there's some shifting thought there, and hopefully we'll have
great.
more research to help define those guidelines a little bit more.
Yeah, and the risk factors are huge. I feel like, if we're recommending somebody who's 65 get a DEXA scan for the first time and they've constantly shared with their doctor that they haven't exercised and they're sedentary and they have a driver to work every day, then that's somebody that I feel like should be screened a little bit sooner.
So we have a physician and an exercise physiologist here, and you've both mentioned like other disciplines that you bring in. It sounds like sort of bone health is one of those things where an interdisciplinary team is really helpful. So can you just talk a little bit about that? How do healthcare providers across disciplines, sports medicine, endocrinologists, orthopedists, physical therapy, exercise physiology, nutrition, psychologists, like how do they work together in a situation with a woman with a bone health issue?
Well, again, we're talking about this collaboration aiming at all of these different spectrum of goals. So having that team collaborating and supporting is going to make the woman or the patient feel more confident that she's making the right decisions. Bone health strategies can be confusing. There's so much information out there. So we don't have a lot of confidence that we're doing the right things. And so if we're all consistently saying the same in our messaging and our collaboration and our goals, that's going to help them feel more confident and more appreciative of the strategies that they're adapting to.
And at HSS, we're really fortunate with the Women's Sports Medicine Center. We do have a multidisciplinary group. So we have metabolic bone specialists, endocrinologists, nutritionists, exercise physiologists, mental health providers, and physicians all working collaboratively together. But not everybody has that out in the community. So trying to identify and find your people that are going to be in your network is important. And as the patient, being your own advocate to try to identify who's going to be part of your team is really important. But it also takes other people and providers who are going to identify somebody who might be at risk. And that's often where I think we fail in medicine is if somebody falls, if somebody has a fracture, that bone health should be a part of the discussion, and often it's not. So every distal radius wrist fracture, every proximal humerus, the shoulder, obviously the hip is the one we think about, but other fractures should warrant a discussion and referral either to their primary care physician, their gynecologist, endocrinologist, metabolic bone specialists. There's multiple people who can take care of osteoporosis and help with treatment.
And just to sort of clarify, your role as a sports medicine physician who specializes in athletes and bone issues, what's the difference between what you do and what, let's say, a metabolic bone specialist or
And I
endocrinologist would do?
often refer and work collaboratively with a
Hmm.
lot of our metabolic bone specialists. In my practice, I don't do osteoporosis medication management, for example. So I will often refer to them, or if I feel like I just want a second set of eyes, a different perspective, I'm a sports medicine doctor. I'm not an endocrinologist. So if I'm concerned there might be an endocrine issue or something I could be missing, then I'll collaborate with them, and vice versa. If they feel like they're seeing somebody who's active and needs a little bit more guidance on the exercise components to it, or they have an injury, I might see them. I might refer that patient to Calissa for further care. So that's an example of where it might be multidisciplinary.
And when do you typically bring in a nutritionist or a psychologist in this case?
A lot of that is in my patients with the female athlete triad or relative energy deficiency in sports. So, somebody where I'm concerned they have an eating disorder or disordered eating, or I just want a further evaluation of that to make sure that what I'm getting from them is accurate and that's not an issue. So, I'll refer to them for kind of diagnosis purposes, but also for treatment and general advice, particularly in an athlete, explaining that you need to fuel as an athlete. And so that sports nutritionist can be really beneficial because they understand your needs as an athlete. And then the mental health providers for a variety of things. Again, if somebody seems to have some disordered eating or what I would just describe as an unhealthy relationship with their food or an unhealthy relationship with their exercise. The other piece is somebody who's not managing their stress well, maybe not sleeping well, or has had an injury. And I know that the impact of that injury and being taken out of their sport can be a really big challenge for somebody who identifies as an athlete. All of a sudden, that identity feels taken from them. That can be a really difficult time for some of our patients.
And how does somebody find a bone health specialist?
There's lots of different people who can manage bone health issues. So it might be your primary care physician, it might be your gynecologist. There's rheumatologists, there's endocrinologists, there's primary care, there's orthopedic surgeons that all can specialize in metabolic bone or osteoporosis management. So we have a department here, a metabolic bone service, and it's a group of all of those two people that are part of that service, along with some advanced practitioners as well, like nurse practitioners and PAs can also be a part of that team.
And are there some innovations or emerging research that you're excited about in this area?
Oh, I hope so. I think for me, the perimenopausal group is, I think, really an interesting area that we still have a lot to learn, and there's been a lot of momentum. So I hope we continue to find ways that hormone replacement therapy and nuances within that area can help bone health. It's not brand new, but there's been more research on sort of the how the hormones are supplied, particularly in like younger patients. So birth control pills, for again, not to get too sciencey, but they just don't get to the bones in the same way as it does when you don't do it through the stomach and it doesn't go to the liver. So using transdermal or a patch for estrogen seems to have more benefit to the bone in the younger population who needs that. So that's some of the area that I think is most interesting.
And and I always just remind my people in my class that there's a lot of research out there, and getting clear evidence-based research, and making sure that these studies are wide, large number groups, instead of taking something that says, oh, you should all be wearing weighted vests while you're doing your house chores, and they test it on 4 people. These are the things we want to steer clear of. So just really just getting that clear, concise, evidence-based research out there, and anything supporting the higher impact and the benefits of that is going to be important for the exercise piece.
And finding great information online and using AI even to help um, arm yourself with the right questions and information when you're going into your provider, but also understanding that you can find a study to support almost anything, but may not be a high quality study or may not be enough studies or enough of a population to be a practice changing behavior. So it's important to sort of take it with a grain of salt. But I always encourage my patients when they come in and apologize about Googling something, I say, no, that's fantastic. You should be armed with the right information and the questions so that we can have a discussion about it. And you've already done some of the background work. So I think it can be great.
And then finally, how can we better educate and empower women to take charge of their bone health? Do you have any ideas on that?
Well, knowledge, number one, support with this collaborating team, the right tools, the right exercises, the right strategies, but just building them lots of confidence. Again, we want to make sure that they have the right information, clear, concise, evidence-based research, and understanding what that means and how it applies to them, and that individualized approach, making them feel like that their team is really about them and not just this kind of umbrella term of bone health, but let's see what you need and what you have, and having that education and that empowering from the team is going to really be the biggest key. And I think understanding the whys of all of this, making sure that our clients and patients understand why they're doing something, they're going to be more likely to adhere to a program. So we would just want to make sure that they understand why, and who, what, why, where, and when.
And I think it's hard, especially when I'm talking to my younger population, to get them to really understand why osteoporosis matters, to circle back to what we started with. You have a higher chance of having an osteoporosis related fracture than your risk of developing ovarian, breast, colon cancer combined. So, and why does that matter? Because the numbers, unfortunately, are not very good if you fall and you break your hip when you're older. About half of the patients don't make it past a year after having that. So that sounds scary, and sometimes that's not exactly how I pitch it to my 18-year-old, but the fractures and the frequent fractures and the loss of muscle mass that happens as we get older, we don't think about it in the same light that we think of cancer and heart disease and those kinds of things. But there can be a lot of pain consequences and even impacting your lifespan, having a fracture related to osteoporosis when you're older. But it's really important to understand that every person should feel empowered to take control of their bone health at any point. It's never too late. It's never too early. You can always do things to improve your bone health so you can prevent those potential consequences down the road.
Well, thank you both for joining us today. I learned a lot, and thank you for tuning in.